Hi everyone, Dr. Simon Friley, consultant in clinical neurophysiology here, and in this video I'm going to be talking about wrist drop. Wrist drop refers to a state where a person is unable to pick up their wrist and or their fingers, and often this is associated with weakness of hand grip too. The reason for that is to do with a concept called bowstringing. Basically, the fibers that of the tendons that come down to pull the fingers down, unless they're kept under a certain amount of tension, much like a musical instrument, then basically they can't transmit their full force, and so one leads to having some weakness in the actual grip strength itself. So it's very important, if you want to have maximum grip strength, to be able to cock your wrist back a little bit, keeps the tendons under the right amount of tension to give you the maximum amount of grip. And people who've got wrist drop will actually have impairment of that. Now, it's often synonymous with problems relating to the radial nerve, but perhaps it might be a bit more correct to think about it in terms of problems with the nerve fibers which are destined to the radial nerve, and those can occur at any of the points, be it from the anterior horn cell, the nerve roots, the plexus, down to the axilla, spiral groove and posterior interosseous nerve themselves. And each one of these have got their own unique patterns of deficits, and we'll dive into all of these a little bit later on in this video. Let's have a look at the anatomy now. There are several bones to consider here. We of course start with the scapular bone and its relationship with the humerus. That's the first bone of the arm. These are followed more distally lower down by the radius and the ulnar bones, and then the bones of the hand. Now, if we just focus in on the humerus, the bone of the arm, we can focus onto the spiral groove, which is a particular indentation where the radial nerve actually winds its way around it. And if we have a look at the nerves now, we can see first of all they have the radial nerve as it comes down all the way down the back part of the arm, but just above it is the axillary nerve, and that's a very important nerve for when we try and differentiate the point at which damage has occurred. So if, for example, there is damage at the brachial plexus level, then we can often expect the axillary nerve to be involved as well. And the axillary nerve actually goes to the deltoid muscle. That's the main muscle of the upper part of the shoulder. It has three heads to it. There's the anterior head, the one at the front, and that rotates the arm upwards. There's the middle head, which pulls it outwards. That's called abduction. And then there's the posterior head over here, which allows the arm to be pulled backwards and upwards. So if the axillary nerve is damaged, then there will be sensory loss over here. This is called the regimental patch area, and also there will be weakness of the deltoid muscles too. Apart from the axillary nerve, of obviously the radial nerve being impaired, and the first group of muscles to be innervated by the radial nerve are the triceps muscles. So these are the muscles that go around the back part of the arm, of which there are three parts. So we've got the long, lateral and medial heads of the triceps muscle. So if there is a problem, a high radial nerve lesion, then the issue will be sparing the deltoid muscle, the muscle that will abduct the arm upwards like so, and it will affect the triceps and all the muscles beneath it from the radial nerve, and one will have problems with extending the arm, and that movement looks like that. So the kind of things that cause a high radial nerve lesion will be the typical Saturday night palsy, so someone who falls asleep drunk with their arm over the back end of a chair, something hard, and that causes a pressure upwards into the armpit. That can actually cause pressure and damage to the radial nerve all the way up there. Similarly, we also have something called a crutch palsy, similar mechanism, people who are leaning on one of these types of crutches for too long, and if it's not been fitted right, then that can lead to such problems. The next level down to consider is a problem at the spiral groove. So here the actual humerus itself is actually quite relatively fragile in terms of what can happen to it, and it's a point where it can actually break. And so if one has a fracture of the humerus, the two bone parts can move away from each other. There can be a stretch injury over there. The fragments can actually move apart, can actually cut through the radial nerve itself. Alternatively, one can also have issues when one is trying to plate it up again, whereby some of the screws or the plating can actually catch onto the radial nerve itself. So there are a variety of ways in which a fracture can actually cause problems. And in fact, lower down in the humerus too. So if one has a supracondylar fracture, that can also cause problems to the radial nerve if there's a posterior dislocation. So there are a variety of ways in which fractures can cause nerve damage. Following that, the radial nerve eventually becomes the posterior interosseous nerve, and effectively it loses the sensory fibers which have branched off before that, and then it innervates the more distal extensors of the hand. And where that occurs is basically just before the arcade of Froude, if I've pronounced that correctly, I don't know. And basically, arch, one has entrapment of the posterior interosseous nerve, which is the terminal motor branch of the radial nerve. If one then has a little look further down, any fractures more distally to the humerus affecting the ulnar radial bones can actually lead to radial nerve injuries. This is an example of a Monteggia fracture over here, and that can cause problems too. So if we consider the different types of causes, there are lots of different causes which can lead to a radial nerve injury. But if we're going to keep this simple, the radial nerve is a very big nerve, and therefore on the whole it takes big things to damage it. Much like the sciatic nerve takes a big thing to damage it, the radial nerve takes a big thing to damage it. And those big things will be trauma, whether it's a shoulder dislocation or a fracture dislocation or an actual fracture either of the humerus, the supracondylar region, or a Monteggia fracture. So those are traumatic causes. There may be compression from a Saturday night palsy, a crutch palsy, or compression lower down at various pinch points. But basically it's trauma and compression are by far the leading causes of wrist drops. So in terms of prognosis now, what may happen, how likely is it for these nerves to repair? It very much depends on where it occurred, what's happened to it, and how bad it is. And in order to answer those kind of questions, one actually has to be assessed and tested for that, usually by an orthopedic surgeon who are experts at making these types of diagnoses and working these things out. Of course, neurophysiologists are involved too, but orthopedic opinion is usually the first port of call for the most part of these radial nerve issues. Now, there are several ways in which we can manage these type of problems. We can either manage them conservatively, where we can watch and wait and see what happens with them. We can provide physiotherapy to try and improve function, and occupational therapy to work with what one has, and of course analgesia if that is pertinent to the situation. There is a more interventional approach as well, which may be more suitable, and that will be a variation of surgical exploration, nerve grafting, and or tendon transfer. Just to have a look at a couple of very specific types of injuries. If we look at traumatic infraclavicular plexopathies, it's a very complex area. It very much depends on what's happened, the nature and extent of the injury, but by far and away shoulder dislocations, fracture dislocations are a very important cause of this. And basically it's best in terms of outcome if these fracture dislocations are reduced promptly, and namely that the risk of nerve injuries actually increase once one gets to over the 12-hour mark. So the quicker one sorts this out, the better. Now, in terms of relocating the shoulder, that can also cause problems, can cause an iatrogenic injury where the doctor causes it. But basically one does need to try and intervene with these as soon as possible. In terms of the prognosis, so the neuropraxic injuries tend to do very well conservatively, so that's when there's just been a simple stretch of the fibers to the radial nerve. However, if the nerves have actually been disrupted, there's axonotmesis, they actually tend to do better with early intervention. So if you have a humeral shaft fracture, in terms of a primary injury, so an injury occurring at the time of the fracture itself, overall, we're talking about 10 to 15% of people will sustain it at the time. Over 70% will actually recover completely by themselves, and therefore a conservative approach tends to be advocated for the first 4 to 6 month period, watching and waiting physiotherapy and so on, and analgesia as required. But if things do not repair, things do not heal up, then sometimes surgical exploration will be required. Now, in terms of secondary injuries, so if, for example, plating has to occur to a fractured humerus, the actual rate of injury can vary between 5 and 10% on the whole, can be more, and that will depend on exactly what's happened, whether it's plate fixation, problems with lacerations, nailing, bone fragments, all sorts of potential causes. And in that scenario, if the surgeon thinks that there may have been an iatrogenic injury there, then early re-explanation tends to be recommended for better outcomes. And overall, if you put the two together, the recovery rates is about 90% in the literature. If we now consider the posterior interosseous nerve, much like the radial nerve fibers, it can either subdivide basically in traumatic compressive or non-traumatic, and the treatment will very much depend on the cause. So sometimes there is reason to give conservative treatment, sometimes it might be a bit more interventional, and the surgical prognosis will very much vary depending on age, length of symptoms, and so it's a bit harder to actually give a specific answer for those kind of conditions. Let's have a look at the actual anatomical aspect of this. Can we have a differentiation of exactly where a lesion might be occurring? So we start off with the brachial plexus, we start with the nerve roots, C5, C6, C7, C8 and T1, and the radial nerve is formed from fibers coming from the upper, middle and lower trunks, primarily from the C6, C7, C8 fibers as they make their way down. These then join together at the posterior cord, whereby they then start throwing off other branches, including the thoracodorsal nerve to the latissimus dorsi muscle, which we'll explore, the axillary nerve, and of course the radial nerve too. This is a bit of a busy slide, so apologies for that. So the nerves themselves are written here in blue. We've got the axillary nerve, radial nerve. There's mention of the posterior brachial cutaneous nerve. It's also known as the posterior cutaneous nerve of the arm. As we wind our way down, we also have a branch just before the posterior interosseous nerve of the posterior cutaneous nerve of the forearm, also known as the posterior antebrachial cutaneous nerve of the forearm, and the superficial radial nerve too, and then one goes into the posterior interosseous nerve, the PIN, and all of its individual motor branches. So if we focus in on the radial nerve, the first muscles that become innervated following the radial nerve's formation are the long lateral and medial head of the triceps, really important in terms of extending the arm itself. And you can see as well that there is the posterior brachial cutaneous nerve, as we'll call it over here, the posterior cutaneous nerve of the arm. This is amenable to neurophysiological testing. However, it's very straightforward to actually test all of those different lateral, long and medial heads of the triceps using EMG. The next important branch to talk about is actually the brachioradialis branch, and that basically will help to flex the arm in the mid position. So not when it's supinated, not when it's pronated, in the midway position. It's one of the flexors of the arm. And just above it, you can also see for 75% of people will also throw off some innervation from the radial nerve to the brachialis muscle, which is otherwise innervated by the musculocutaneous branch. So the brachioradialis is a very important muscle in terms of our localization, and the reason for that will become apparent pretty soon. So if one has a high radial nerve lesion, then basically one is going to have weakness of the triceps muscles, and of course the sensation would be impaired all the way down the hand around the back of the arm. If, however, one has a lesion a little bit lower down, so the innervation to the triceps has already occurred, and also indeed to the anconeus too, then the brachioradialis muscle will actually be the next most important muscle to test, because if there is impairment of that muscle but the triceps muscles are remaining healthy and well, then one knows and one can localize the issue to the spiral groove. Now, there are a variety of other places just distal to the innervation of the brachioradialis that can cause problems with the wrist drop. I've seen this personally a couple of times with biceps tendon repairs, and in this scenario one could actually have a situation where, for example, the extensor carpi radialis longus innervation is impaired and all the extensors beneath that, and also one can have impairment of the posterior cutaneous nerve of the forearm. So basically all the sensation is lost in the back of the forearm, but preserved at the back of the arm itself, or other variations where that is preserved but the innervation to the superficial radial nerve is impaired, together with the PIN muscles. So it can be a little bit of a dense area, and one can have some rather mixed pictures of what's going on. However, in the posterior interosseous nerve lesions, it's very clear that there should be no sensory loss, and it's a pure motor deficit. And over there it will be a deficit from the extensor carpi radialis brevis, and so there will be some radial deviation when one tries to get the patient to do some wrist extension, because there will be still some strength from the extensor carpi radialis longus, but the extensor carpi radialis brevis will be weakened. So extension of the that radial aspect of the wrist will be weak, but it won't be completely weak. And of course all the other muscles are beneath that too. So just summarizing all of these different areas in this table. So in terms of sensory and motor deficits, so if one has a lesion in the posterior interosseous nerve, there'll be no sensory loss. In terms of finger extension, there will be finger extension weakness more than wrist drop with radial deviation, as I've explained, because you'll still have the branch going to the extensor carpi radialis longus, giving some strength to the actual wrist itself, will allow for some wrist extension to occur. If it's occurring just above the posterior interosseous nerve, so then there may be some sensory loss if the actual superficial radial branch has been impaired, and one will have finger and wrist drop, plus or minus radial deviation, depending exactly on where that's occurred. Higher up, at the level of the spiral groove, again one will have sensory loss, dorsum of the hand, back of the forearm, and there will be motor impairment, finger and wrist drop, and weakness of arm flexion because of the impairment of the brachioradialis. If it's higher up in the axilla, then one will actually have sensory loss around the posterior aspect of the upper arm, and one will also have motor deficit of finger and wrist, and weakness of arm flexion because of brachioradialis, and also arm extension from the tricep muscles. If it's in the distal posterior cord, so that's involving the axillary nerve, so it's all of the above, plus also weakness of abduction of the arm. And if it's mid-posterior cord, where one is also involving that thoracodorsal branch, which goes to the latissimus dorsi, then one will also have a problem with adduction of the arm. So that's this movement over here, like so. Or one can have a resisted movement that way. So there are all sorts of various different patterns with which a radial fiber issue leading to a wrist drop can be explored anatomically via clinical examination and via neurophysiological study. So I hope that summarizes actually what's quite a complex topic in terms of the anatomy. I'd also like to thank my model for kindly demonstrating the different muscle groups. Sadly, it wasn't me who could do that modeling for you, but thank you to the model who prefers to remain anonymous. Please do support the channel by liking, sharing and subscribing, and I look forward to seeing you on the next video at some point. All the very best.